One, sitting here with Dr. Fabian Pitoia from Argentina. Fabian, welcome.
Thank you very much for the invitation.
So good to see you. It's been a long time.
Yes, a long time.
And the topic is the treatment of advanced thyroid cancer.
Yes, we are very enthusiastic with the new things that we are learning about the treatment of advanced thyroid cancer. And when we talk about advanced thyroid cancer, we usually have to split it into medullary thyroid cancer, radioiodine refractory thyroid cancer, and then anaplastic thyroid cancer. If we go to the first group, the medullary thyroid cancer, we have now more therapeutic options. We have multikinase inhibitors, vandetanib and cabozantinib, that were already approved. And now we have selpercatinib and pralsetinib for those patients who are RET positive. They have a RET mutation. So we have several options for these patients, and it really changed how patients do with this kind of medications. I mean, the time the patient remain stable on their disease and they continue on survival. The second group of patients is the radioiodine refractory thyroid cancer. This group of patients do not respond to radioiodine, so they become refractory, and we have options that were already approved, sorafenib and lenvatinib, but now we also have specific genes that were found altered, which can be targeted on. And these genes are NTRK, BRAF, RET PTC. So these alterations now have specific treatments, and also the response to treatments with these new drugs, selpercatinib, pralsetinib, larotrectinib, and entrectinib, are really very, very impressive, with overall response rates of almost 70 or 80%, and median overall survival not reached, a median progression-free survival of almost 3 years. That means that these drugs, what they do is stop the disease. Even we have complete response, the patient disappear all the metastatic disease, and we have long time of action of these drugs. This changed a lot. And the most important thing is what happened for anaplastic thyroid cancer. This group of patients died in 1 year. And now we have options, at least for those patients who harbor a mutation, which is the BRAF mutation. And for those patients, the combination of dabrafenib and trametinib. And if you can do a surgery, neoadjuvant therapy, I mean, you use dabrafenib, trametinib, and then you go to the surgery, you may have even complete response in a patient who before didn't have any alternative. You didn't have any option. So this changed the world for anaplastic thyroid cancer. So I think that for us, these new drugs open a new window for hope for this group of advanced thyroid cancer patients.
Great. For any patient that might be watching this interview, what is the progression from maybe papillary thyroid cancer to advanced? Can it happen?
Yes, it may happen. Around 10% of papillary thyroid cancer may present with advanced disease. The same happens with medullary thyroid cancer, which may present with around 20% of patients with advanced disease. And all the anaplastic thyroid cancer usually have advanced disease. So it is something that happens infrequently for differentiated and medullary thyroid cancer, but we see it a lot as a referral center in our hospital. So most of our patients are advanced.
And we're talking about then 4 different types of thyroid cancer.
Medullary, papillary, follicular, both of them are radioiodine refractory thyroid cancer, differentiated. We can also include there the poorly differentiated thyroid cancer, and then the anaplastic thyroid cancer.
Are the symptoms different for each?
Yes, of course. When we have advanced medullary thyroid cancer and we have metastatic disease, we can have symptoms that are produced by some proteins secreted by the tumor, and some of them, one of them is the calcitonin. There are others. They may produce diarrhea as a symptom when there is advanced disease, when there is a large tumor burden. And for papillary thyroid cancer, you only may have symptoms if you have a locally advanced disease. I mean, when you have a tumor that invaded and you can see in the neck, and probably it is unresectable, and then we have now new options for treating these patients.
Are there characteristics to the patients that you have noticed that are more common in certain types of cancer?
No, I think you don't have a specific thyroid cancer. When it is locally advanced, it will produce the same symptomatology. I mean, patient will have a lump in the neck, which is invading structures and may produce local symptoms.
How common is the advanced thyroid cancer?
Luckily, it is uncommon. But probably we are biased because we see as a referral center a lot of patients with advanced thyroid cancer. But when you look the whole population of differentiated thyroid cancer, I mean papillary thyroid cancer, you will find that 90%, 95% of them will have a curable disease with no other problem. Then the other will be patients that we have recurrent disease, but this is not advanced thyroid cancer. They can be cured with a new surgery. And then advanced thyroid cancer is when you have metastatic disease, and this metastatic disease becomes radioiodine refractory.
What can you tell those watching who have more serious forms of thyroid cancer that is reason for being optimistic more today than they could have been 5 years ago?
Yeah, sure. I always try to say when I have a patient like that is very, very upset or probably very sad because of he's thinking about death, I think we have a lot of options right now, and we can prolong the time for this disease to progress. So this is something that changed a lot. And when the patient understands, because sometimes in this patient you do not do anything, just you make an active surveillance, the same that you do with papillary thyroid cancer, you can do it with a metastatic disease in the lung. If it's a tiny metastatic disease, the patient can be stable at 5-6 years until you decide, well, the patient progressed, the lesions grew up, so you can now start, for example, a multikinase inhibitor. Then you have different lines. You can use one, and then you stop the progression for 2, 3, 5 years, and then you can use a second line, and then you can go to analyze the genes and to know if there is a specific mutation to use a specific drug, and then you can have even longer progression-free survival. That means that the lesions will remain stable with new lines of treatment. So this changed a lot. We had only one line that was sorafenib in 2013. Now we have sorafenib, lenvatinib, dabrafenib, trametinib, and then depending on the mutation, selpercatinib or pralsetinib or larotrectinib or entrectinib. And these opens new windows and new hope for the whole population of patients with thyroid cancer.
And you did 2 presentations on this topic already at the World Congress on Thyroid Cancer here in London. What was some of the response?
We had 2. One is telling the story from the Latin America perspective. It's something that probably is different, how we have to be creative with things, we have to move on differently. Luckily, in Argentina, at least, we have all the drugs available except for selpercatinib and pralsetinib. But the rest are available, and it is almost always reimbursed, so we can use it in every patient. It is not the case for all the countries in Latin America. So showing that reality is interesting to show how in different parts of the world we cannot do the gold standard. We need to adapt, we need to be creative, and then to, again, press the industry to bring these drugs to our countries.
Before we say farewell on this topic, any final thoughts to share with them?
Well, just to say, I always want to transmit to the patient that there are options, that you need to be calm. There are options. You need to search for people who specifically treat thyroid cancer, advanced thyroid cancer. This is not something that any oncologist can treat or any endocrinologist can treat. There's groups, referral groups in each country. You need to search for those groups in order to find the correct option for your disease.
Thank you.
Thank you.
Farewell, everyone.